another disease or another terminology that is known as smoldering multiple myeloma. So this is asymptomatic plasma cell dyscrasia with higher risk of progression to multiple myeloma. So what are the three criteria which we see in this? M protein more than 3 gram per deciliter, whereas in AMGUS it was less than 3. Then there is the CRAB criteria is absent in this condition also, but this clonal bone marrow criteria is, that is abnormal bone marrow cells, plasma cells are in between the AMGUS and multiple myeloma. So they are between 10 to 60%. In AMGUS, it is less than 10%. In multiple myeloma, it is more than 60%, but there it is borderline in between these two. So this condition is also, it is basically this condition progresses fast to multiple myeloma. So these are the three criteria which we see in, because clinicians take into account that close follow-up has to be done in these persons who are diagnosed with smoldering multiple myeloma. So these are the three criteria which we have to keep in mind. Then coming to the very, very important condition, multiple myeloma. So what are the criteria? I've already discussed. So if we compare with the previous two conditions, M protein more than 3 gram per deciliter, which is seen in smoldering, but not seen in AMGUS. Number 2, coronal bone marrow plasma cell more than 60% and presence of and damage, that is CRAB criteria is present. What is that? Again, we will have a look. Serum calcium more than 11.5 milligram per deciliter. Calcium levels are high. Serum creatinine, that is renal failure. The patient is going towards renal failure. Renal damage is there. Creatinine is more than 2 milligram per deciliter. Sudden onset of anemia, and there are lytic bone lesions on X-rays. So this is the hallmark of multiple myeloma. So now just have a look. Whenever we find abnormal immunoglobulins, so we suspect either it is polyclonal or it is monoclonal gammopathy. So what are the investigations? We advise for serum protein electrophoresis, we advise for urine electrophoresis. What we find an M band, that is the diagnostic of multiple myeloma or gammopathies. So further we have to proceed with immunofixation. So immunofixation, what we find, we can segregate between heavy chain and light chain typing. So if it is heavy chain can be further of, mainly it is of IgM or non-IgM. So IgM type is because of Waldenstrom's macroglobulinemia, and non-IgM type is mainly because of IgG. In 52% of patients we get IgG, 20% we get IgA, and remaining 2% we get IgD or IgE. So it is IgM or non-IgM, and light chain is classified into kappa or lambda diet. And 16% is contributed due to the light chain disease. So now you can just understand that what is the significance of immunofixation. We may not reach to a conclusion if we don't do this test. So ultimate, the final diagnosis is done with the help of immunofixation only. So now you can have a look at these two patterns. So to differentiate between polyclonal and monoclonal gammopathies. So this broad peak in the gamma region is seen in case of polyclonal gammopathies, whereas in case of monoclonal, you can just have a look. This is a sharp spike, church spire peak, it is known as. So very sharp spike you see in a monoclonal gammopathy. So this type of pattern we get in after the electrophoresis is done, after the serum protein electrophoresis is done, and we differentiate between polyclonal and monoclonal gammopathies. So now what type of monoclonal gammopathy, which immunoglobulin is raised, that can be done further by immunofixation. So now, in a monoclonal gammopathy, the large spike in gamma region is there. So I've already told it can be IgG, M or IgA from a single B cell clone, which is produced in excess. So these are mostly caused by hematological disorders, including multiple myeloma, Waldenstrom's macroglobulinemia, heavy chain disease, and aegis. So how do you interpret sharp spike, very narrow M band? M protein is considered to be measurable if it is more than 1 gram per deciliter in serum or more than 200 milligrams per day in the urine. So if the levels are more than 1 gram, then only we can measure it. Now, just have a look. This is the graph in case of monoclonal gammopathies. IgG kappa is the monoclonal peak in gamma globulin region. So these are the different IgG, IgA, IgM, various subtypes can be seen with the help of immunofixation. So now these are the, we have already discussed, but again you can have a look at this table. So what is the differentiating, what are the various differentiating features between, because you have to give diagnosis in this case. You cannot just give the tracing or give the value to the clinician. Clinician will ask you, what is the diagnosis? So we have to keep in mind various conditions which are leading to the change in levels of these monoclonal bands. So smoldering multiple myeloma, aegis, that is monoclonal gammopathy of undetermined significance, and multiple myeloma. What are the differences? You can have a look. In aegis, the level is less than 3 gram per deciliter. There is less than 10% plasma cell involvement. Then affected patients have no M protein in their urine, no lytic lesions, no anemia, no hypercalcemia, no renal disease. That is absent CRAB criteria. Then smoldering multiple myeloma, levels are more than 3. Greater than 10% plasma cell involvement, affected patient, no lytic CRAB criteria is absent in smoldering as well. Then multiple myeloma, number 1 on the table. So narrow spike, very sharp and narrow band, but M protein levels are greater than 3. This is very important differentiating point. Lytic bone lesions are there. Of course, the clinician is there to correlate it with various other diagnostic modalities. He performs CT scan, he performs MRI and other investigations also. But the levels of M protein is very important. As a lab expert, you have to keep in mind this point. Then in plasma cell leukemia, in solitary plasmacytoma, in Waldenstrom's macroglobulinemia, what are the levels and what are the clinical features you have to keep in mind as well. So in case of heavy chain disease, M protein has an incomplete heavy chain and no light chain. In case of Waldenstrom's macroglobulinemia, you get IgM protein. So these patients have hyperviscosity and hypercellular bone marrow along with these clinical diagnostic features. Now, what is the further course of action? Once you see M protein spike on the serum, if the levels are less than 1.5 grams per deciliter, what you do, you keep a follow-up and you perform serum protein electrophoresis annually. So this chart we have to actually paste in our lab where we are performing these investigations. So if the levels of this protein, M protein is between 1.5 to 2.5 gram per deciliter, we perform nephelometry to quantify again the levels of proteins, and we perform 24-hour urine collection as well. If the levels of this serum protein electrophoresis protein is normal, then we keep a follow-up after 3 to 6 months. If again it is normal, then the test is performed annually. But if it is abnormal in serum and urinary protein electrophoresis, we refer the patient to hematologist, oncologist. Now coming to high levels, that is if the levels are more than 2.5 grams per deciliter, and a patient also presents with bone lesions, then the CT scan is also positive, then other investigation like C-reactive protein levels and beta-2 microglobulin levels are high. So we have to do other investigations. We have to do serum protein electrophoresis. We have to do urine electrophoresis. We have to perform immunofixation. So if the levels are normal, no worry. We perform serum protein electrophoresis after 2 to 3 months. If again it is normal, then again repeat it, and then we perform it annually. But the levels are normal, definitely patient needs aggressive treatment, and we refer the patient to hematologist, oncologist. So this is very, very important. Now, polyclonal gammopathy. So I've already shown the graph which we get, that is a broad peak in the gamma region. That is broad diffuse increase in the gamma region. And this can be seen in, this may not be a malignancy. Generally, it is seen in infections, inflammations, and autoimmune diseases. So what are the various conditions? Again, sarcoidosis, pulmonary tuberculosis, we see the broad peak in case of gamma region. We can see the broad peak in subacute bacterial endocarditis, some autoimmune diseases as well. So this was about monoclonal and polyclonal gammopathies. So polyclonal are generally not malignant. So this is the differential diagnosis. Just have a look at this table. Infections, connective tissue diseases, liver diseases. So they all lead to, this is a differential diagnosis between monoclonal and polyclonal gammopathy. Yeah, this is a differential diagnosis of polyclonal gammopathy. Other inflammatory conditions, cystic fibrosis, chronic bronchitis, etc., also lead to polyclonal gammopathies. Now, coming to this condition, hypogammaglobulinemia. We also have to keep in mind this condition. So you can see what would be the normal curve and how a normal curve in case of gamma region when it is normal looks like, and when there is the levels of low, how it is seen as a flat. It is not curved now. So in hypogammaglobulinemia, the pattern is really low in gamma globulin region. So anything that causes a decrease in gamma globulins, decrease in the levels of IgG, IgA, IgM, like in immune deficiency. So they can lead to hypogammaglobulinemia. But I have just talked in the start of my lecture that the levels are low. You may not, this may be misleading many times, because maybe you get the levels are normal in the serum, but the patient, since the patient is excreting light chains in the urine, so this gives a false diagnosis of high levels, any underlying disease condition or any underlying malignant condition. In 10% of cases of multiple myeloma, you get normal values of gamma globulins in serum, but you are detecting light chains in urine. So to further diagnose a monoclonal gammopathy, that is very, very important. So we have to do immunofixation electrophoresis. So this IFE will separate the gamma region into IgG, IgA, IgM, kappa chains, and lambda chains. So this test differentiates what type of monoclonal gammopathy a patient has, whether he has heavy chain disease, whether he has light chain disease, and the heavy chains can be IgG, mainly IgA or IgM types can be present, but light chains are kappa and lambda types. So just have a look at this immunofixation. We are getting in M band, we are separating IgG, we are separating IgA, IgM, kappa and lambda chains by means of immunofixation. Yeah. So basically this technique combines both electrophoresis as well as antigen-antibody reaction. So sharp band corresponding to antisera added depicts the heavy chain and light chain. In case of only light chain band with no heavy chain band, myeloma is to be ruled out. So this fibrinogen interferes, so you should ensure that there should be no hemolysis. No hemolyzed sample should be entertained for performing this test. So just, I will go fast. We can get a change in the patterns of other globulin apart from gamma globulin region, that is alpha 1, alpha 2, and beta region, that is beta 1 and beta 2. So we all are aware of these conditions. Alpha 1 antitrypsin deficiency, it is a major protein in this region. So this is seen in liver and lung diseases. So we get, you can just see how we have already seen how a normal graph looks like, and here you can just compare alpha 1 band. So this is missing in case of alpha 1 antitrypsin deficiency. So whenever you see such type of curve where alpha 1, you can just report this and you can advise the clinician to coordinate it clinically. Then a few inflammatory conditions, mainly in acute inflammatory process. So there is increase in alpha 1 and alpha 2 bands. You can just have a look at how the inflammatory state and how a normal condition looks like. So there is mainly increase in the bands of alpha 1, alpha 2, beta. Almost all alpha and beta regions, they show a increased spike as compared to normal. Now, chronic inflammatory. So late response is correlated with chronic inflammation. So just comparison is shown here. In we can see these in autoimmune diseases, in chronic liver disease, chronic infections. So there is also rise in the band of beta region. Now in cirrhosis also, yeah, there is very hallmark when you see the curve in case of cirrhosis that is known as beta gamma bridging. So you can see the when you have a look at the beta in between the beta and the gamma region, so that demarcation is lost. So a small sort of bridge is found between the beta and gamma region. So this is seen in cirrhosis. You know what are the various causes of cirrhosis. So whenever the patient of chronic this alcoholic abuse or viral hepatitis is there and underlying cirrhosis is there, so you get to see such type of curve. So in nephrotic syndrome also, we know that there is loss of albumin in nephrotic syndrome, and the levels of albumin are low, but the levels of alpha 2 and beta increase compared to albumin, and you get a increased spike in case of alpha 2 and beta region. So this is a comparison of gel and serum protein electrophoresis, which is shown here. So similarly, increased transferrin also contributes to beta sharp and increased band in case of beta region. Now coming to urine electrophoresis. So how we obtain? We obtain concentrated urine. So we have to collect 24-hour urine sample. And how we obtain concentrated urine? By ultracentrifugation, by ultrafiltration, by vacuum dialysis, or by centrifugation. So we see many in many conditions I've already discussed. We see small size light chains with only small amount of intact globulin. Intact monoclonal immunoglobulin is seen in patients with poor renal function also. So how light chains, you can see very sharp band seen of light chain seen, that is shown in this diagram, in this figure. How this contributes to diagnosing this condition. So this is very, very important. So basically we have just to conclude that we have to do, whenever we are performing serum protein electrophoresis, we have to perform urine electrophoresis, we have to perform immunofixation, and Additional point to consider is the size of amputee spike. So although this spike is usually greater than 3 milligram per deciliter in patient of multiple myeloma, up to 1/5 of patients with this tumor may have an amputine spike of less than 1 gram per deciliter. So we have to consider the size. Hypogammaglobulinemia on serum protein electrophoresis occurs. So this is very, very important. It occurs in 10% of patients with multiple myeloma who do not have serum amputine spike. So most of these patients have large amount of Bence-Jones. I've already discussed that they have large amount of Bence-Jones proteins, that is monoclonal free kappa or lambda chains in their urine. So many times the size of amputine spike in the serum is also not helpful in excluding the multiple myeloma. So we have to combine the serum with urinary with immunofixation. So another thing is monoclonal gammopathy is present in up to 8% of healthy geriatric patients as well. So all these patients with monoclonal gammopathy, they require further evaluation to determine the cause of abnormality. So I've already talked about MGUS and smoldering multiple myeloma. So we have to perform nephelometry to quantify the immunoglobulin whenever they are present in high amounts, and we have to obtain 24-hour urine collection for electrophoresis and immunofixation. Then, of course, the clinician clubs it with investigations like CT scan and bone marrow aspiration. So we are doing two-dimensional electrophoresis, which allows for a more complex analysis of proteins, which are separated by means of both size and charge. So another latest one is microchip electrophoresis, which is another recent advancement, which miniaturizes the process into tiny chip. So which increases the speed and efficiency. Thus, to conclude, electrophoresis is a powerful tool in scientific research which offers a versatile method for analyzing the macromolecules. So as technologies continue to advance, the future of electrophoresis is very, very promising. And so it continues to be a widely used technique in proteomic and genomic research, disease diagnosis, drug quality control. So with advancement in automation and data analysis leads to more precise, efficient, and versatile applications in various fields. So thank you so much. Yeah,
thank you for such an excellent session.
Thank you. Thank you very much, Dr. Rachna Sabarwal ma'am, for such an informative and insightful talk on recent advances and clinical applications of electrophoresis. I'm sure all the attendees found this session highly relevant and valuable to their practice. And now I will, after this presentation, we will have a short question answer session. I request all the participants, any query they have, please ask ma'am. Thank you.
Any queries? So electrophoresis has significantly advanced biochemistry by providing powerful tool for separating, analyzing, and identifying biomolecules. I hope I'm audible.
Yes, ma'am, you're audible.
Okay, thank you. Its application spans from basic research to clinical diagnostics and forensic science also. There is ongoing advancement in electrophoresis for enhancing its resolution, throughput, and versatility. Thank you, Dr. Rachna Sabarwal, for your such an elaborated and informative talk on electrophoresis, covering all the aspects of electrophoresis. And this this had been enriching for all of us.
Thank you so much.
Thank you. Thank you. A big thank you to Dr. Anita and team for conducting these webinars and giving us the opportunity. Questions, please. Any questions?
Other chairperson,
We can go to next session then.
sir. अच्छा, सारिका मैम, please unmute yourself. Dr. Sarika ma'am, please unmute yourself.
Okay, now I'm doing. Hello. Uh, so I'm very much grateful that Dr. Sabral ma'am also such a one and informative and it is very helpful as we can apply this knowledge which has provided us in the practical scenarios and as the future trends this we can do it this automation will be so actually it is automated also so it will be very helpful for us. Thank you.
Yes, sir. Please unmute. Dr. Rachit sir, please unmute. Yes, yes. Dr. Rachit sir, yes, sorry, Professor, please. Dr. Rachit sir, please unmute the mic. Dr. Rachit sir. Yes, sir. Yes, sir. Welcome, sir. सर ने बोला कैसे ट्रेन कैसे इक्वल Anybody have any questions? So they can unmute their mics and ask.
Very good morning, everybody. That was an excellent session by Dr. Rachna ma'am on electrophoresis. All the sessions were good. I have a doubt. Can I proceed with my doubt? Am I audible?
Yes, ma'am, you are audible.
Yeah, I just wanted to know what are the methods for quantification of this M protein? Hello?
Yes, ma'am, you're audible.
Yeah, what are the methods for quantification of this M protein?
Dr. Rashna, ma'am, are you there? Please join. Dr. Rashna, ma'am, please join and answer the question. Answer the question. Okay, ask it. खाने में
Hello,
I think Rachna ma'am left. I think Rachna
anybody?
ma'am.
Okay. Fine. If anybody else can answer, that is also fine.
Yes. Ma'am, Rachna ma'am left.
Hello.
Hello, hello, ma'am. That was an excellent session, ma'am.
Sorry,
Short
I'm not
and
Dr.
crisp. It was just a doubt. It can be clarified later also, ma'am. It's okay.
Okay, ma'am. Our next speaker is Dr. Jayachandran.
He will be joining in a
Has joined, sir has joined or not? Dr. Jayachandran. Dr. Jayachandran sir will be briefing about Ambicon 2025, which is going to be held in Coimbatore.
Okay. Thank you,
Welcome,
madam.
sir.
Can you hear me?
Yes, sir. Yes, sir, we can hear you.
Okay. Shall I have a presentation, small presentation?
Yes, sir.
Good morning, sir. We welcome you all.
Good morning. Good morning. Okay.
Since we all know the Ambicon 2005 is going to held at PSG, Institute of Medical Science, Research, Coimbatore, Tamil Nadu. I request sir to elaborate
Yeah.
and share his ideas about the upcoming biochemistry event.
Okay. Can you able to see my screen?
Yes, sir.
Okay. Thank you, Anita, madam, and thank you, one and all present here. I am thankful for the opportunity. Ambicon 2025. Okay. So last December, Central Ambic has allotted the Ambicon 25 to Tamil Nadu. Okay. Thank you for all the support from Gujarat and all the states. Okay. And because of your support, we are conducting now. And once we accepted this, all our seniors has told that start working from right from the beginning, and we have been working from the beginning. And this workshop PSCIMSR in Coimbatore, we have got a good infrastructure facilities. We have got a auditorium waiting for you, and we have arranged the the dinner session in Jenny Residency. That's a bigger area what you are seeing, and we have got lot of breakaway rooms. So all our classrooms are LED walls, and all our demo halls are having LCD projectors. So we can have a number of split up rooms. And this is our lawn next to our auditorium, and here is going to be the stalls, and central will be the food court. Okay, so we are going to enjoy, we are have a lot of a good time here. Okay, and this is another auditorium which is having around 400 500 capacity. Okay, so we are eager to host and a very good event here. And say here we work together, not only PSC IMS or the Government Medical College, Karpagam and KMCH, all the workshop, all the medical colleges in and around the Coimbatore. We are thinking all the ways to make this event much more enjoyable and much more contributory. Okay. So these are the main schemes: next generation sequencing, mass spectrometry, metabolomics, medical education, and laboratory management. We are giving equal opportunity for us all these things. The main theme of the conference itself is next gen biochemistry. So this is our idea to define what is the next gen biochemistry. Okay, so next gen biochemistry we are going to have it here. So so this one, actually, we have got a MS, we have got a SciEx machine in our own college, and outside we have got a Waters instrument. We are arranging workshop in both, and we have got a lab management. We have got total of automation in our college, and nearby 2-3 places are having total of automation. We can demonstrate the total of automation there. Okay, and metabolomics. Okay, there are many workshop in the metabolomics also, and this thing say next gen sequencing, Sangers, whatever you name it, we have got one instrument in our place, and a few instruments outside also. So we have designed many many workshops we have designed. Not only the hi-fi things, we have got workshop in something rare thing like okay, or say object. It's a programming language, but what we can do wonders with the R software, and that one person is conducting a workshop on that. Okay, like that we have got a immense workshop, all the workshops and everything is there, and we are planning the lot of sessions also. So Ambicon 2025 is this version. This is the website, and actually this time we are planning many new things, like TED-like talks. That means some 5-minute talks from any faculty, junior, senior, doesn't matter. Okay, and like that 5 minutes talk, lot of talks, like that we are planning some sessions. Okay, it should be interesting, it should be to the point, and other scientific sessions also in the same okay, this in these okay streams, in these streams we are trying to get a very good scientific sessions, and we have got a very good contribution from the all the IVD market. All the companies as sponsoring, willing to sponsor well, and we want to define the biochemistry. We want all the biochemists to come together and have a good interaction with the IVD market. Okay, and with this in mind, we have done like this. Okay, this is the say our registration fee structure. If you can see, say the fee for the workshop, we have kept at 1,000 rupees, just to make that it is very affordable. Actually, we cannot. We are almost say subsidizing all the workshops with our with the other money and all. Okay, and for this thing also, for conference also, post graduation we are say we are giving it for 6,000. Okay, and for, as an early bird. Okay, all these things are okay. So actually, we are going to cut down the lot of expenditures, so we don't go for very high-fi this thing website and all these things. It's costing around 5 lakhs, so we settle for some 40,000 and all. So the registration website may give some problem. We'll overcome this problem and we will register. We will focus, we will direct our money only for spending on the learning and our stay and our comfort, our togetherness. We will spend it on like that. Okay, just note down this website, www.ambicon2025.org. This is where you are going to register. Okay, and see, all these seats are there. Okay, expecting you to come, and say this is a time to define our biochemistry. Okay, we have to define biochemistry. We have to come together. We have to share the expertise. We have to develop a vision, and we have to move forward. Okay, meeting annually once together and networking and sharing our thoughts and improving ourselves is a mandatory thing for every one of us. Okay, in this context, I welcome you all to the Coimbatore. Okay, we are doing everything possible to make this workshop successful, but it is only you can make this successful. Okay, our respect comes from number of people coming only. Okay, our respect with the IVD market, our respect with any other people, everything comes from the our own togetherness only. And I promise you that none of your time will be wasted. It will be a very useful time spending it here. Okay, so this Ambicon we are conducting by Tamil Nadu chapter. But the thing is that we are together with Pondicherry chapter and we are together with the Kerala chapter also. So many people helping us, so many people contributing, and we are moving this say conference preparation forward. Okay, welcome to PSG. We are ready to host you. Okay, thank you immensely for this opportunity. Okay, thank you. Any questions? I'll be like to. I will like to answer.
Congratulations, Dr. Jayachandran. And we are
Thank you,
all
madam.
looking forward to come to Coimbatore.
Madam.
Thank
Any
you,
other
sir.
question?
Any questions? Yes, madam. Thank you.
Any other
Any
questions
questions?
from anyone?
Can the early bird be extended till the end of September?
There is a question in chat, sir. Can you please extend the early bird period up to 30th September, if possible?
Early bird. You want to extend it? Okay, 30th September. No, we have put 15th August. You want it until 30th September. Okay, I will talk to my people. We may extend it to 10th September will be good for you.
Yes, sir.
10th September. Well,
Yes, sir.
okay, I will talk to my team and I will extend to 10th September. Okay, not more than that.
Okay, okay, sir.
Okay.
Thank you so much, sir. The
Yeah.
plan discussed by you seems
Please,
fantastic.
every faculty and all people, please do come. Okay.
Yes, sir. We hope for very best for Ambicon 2025 conference and wish for maximum participation. Thank you, sir.
Thank you so much, sir.
Thank you, sir.
I will. Our next speaker, Dr. Shivani Reswal, ma'am.
Thank you. I have joined the session.
Yes, ma'am. Dr. Shivani Reswal, ma'am, is MD Biochemist with 20 years of experience in clinical diagnostics and research. She is presently working as Professor and Head, Department of Biochemistry, India. She is a National Coordinator for the Association of Medical Biochemists of India and represented MB in the 14th APFCB Congress, Tepai 2016, in the APFCB Executive Council. She has also been the corresponding member of various IFCC. Apart from medical diagnostics, she has also obtained fellowship in genetic diagnostics and has been a keen interest in molecular diagnostics. She has projects and presented papers in national and international conferences. For this session, I would like to invite our honorable chairpersons, Dr. Reema Behri ma'am, Professor, FH Medical College, Agra, Dr. Sangeeta Meena ma'am, Professor, Biochemistry, SMS, Medical College, Jaipur, Dr. Sunil Gupta, sir, Professor, Dr. Shilpa Jain, Professor, AIMS Bhatinda. And we can start your session.
Can I share my screen now?
Yes.
Yes, Shivani ma'am.
Yes, yes, Dr.
Dr. Reema Behri ma'am, Dr. Sangeeta Meena ma'am,
Yes, good morning. Thank you.
You may start the session.
Ma'am.
Yes, please.
Minute. I'm HOD Biochemistry GMC. Dr. Anita. Of Rajasthan API. And she's the one who has taken our association in Rajasthan to this level. So we should give a big clapping that she is maintaining this in Rajasthan. So kindly support her, and I'm always with her for all CMEs, what she gives to the faculty. Thank you, ma'am. Thank you. You can start your session, Shivani, ma'am. Thank you.
Is my screen visible?
Yes.
Hello, am I audible and is my screen visible? All right. Thank you so much. So, good morning, everyone. And thank you, Dr. Anita and her team for giving me this opportunity. And I would also like to congratulate Dr. Anita and her team for bringing out, organizing such conferences and CMEs every year. So regularly she's been doing it, and congratulations for the same. So I will be speaking on the use of artificial intelligence in the clinical laboratory. So as you all know that artificial intelligence is nowadays capable of completing tasks with performance characteristics that are almost comparable with human experts. So many areas, including the healthcare system, have now started adopting these technologies. And even in our diagnostics nowadays, this AI tools are being used, for enhancing the diagnostic precision and streamlining the laboratory operations. So in this session, we will look at what is the basic foundational concepts of artificial intelligence, with a focus on how these artificial intelligence tools and machine learnings can be applied in clinical biochemistry. So how we can use these algorithms, data analytics, and for transforming our laboratory processes, and briefly also discuss what are the challenges that lay ahead, before we can actually utilize them in our own daily practice. So just the basics about what basically artificial intelligence is, so that we all can understand the foundational concepts of these terms. So this word artificial intelligence was coined by computer scientist John McCarthy in the year 1955. So AI is basically, trying to simulate with a computer something that would match or even exceed the human intelligence. So that basically brings us to a question: what is intelligence? So intelligence can be defined in a number of ways, but what generally it means is the ability to learn, to infer, and to reason. So that is why the true definition of artificial intelligence is the ability of a computer system to mimic human-like cognitive functions such as learning, problem solving, and reasoning. So in today's times, we interact with AI in a large number of ways. Some common ways that is, I'm sure all of us have encountered AI is the receiving video recommendations on online platforms, streaming platforms like Netflix and Amazon. So you see one kind of shows and immediately it will recommend you similar shows. Similarly, recommendations, we get on the social network sites like LinkedIn, Facebook, Instagram. Again, depending on what we are viewing on these sites, you will get recommendations. They are all AI based recommendations. Even voice command systems like Alexa and Siri, so they interact with you, they respond to whatever instructions and commands you give, and accordingly they respond. And you can set your alarm, call somebody, play a particular song. So they are all AI based applications. And a very common AI application that I'm sure all of you must have utilized at one point, some point, is the use of a chatbot. So whenever we are troubleshooting a problem online, we are asked to write in a chat, and a chatbot is actually responding to our queries and questions, and they also suggest some appropriate resources. So that is a chatbot. And another interesting recent, I will not say recent, but another interesting application is the self-driven cabs, which have been introduced by Tesla. So they are all AI based. There are multiple places where AI is being used significantly. And even the clinical laboratories are not far behind. There are many applications which have come up even in our laboratories where AI can be used significantly. And the two main reasons for requirement of AI in laboratories is one, that in laboratories we are facing increased demands. There are increased workload, and we all deal with shortage of staff. Resources are very often limited, and there is a persistent demand to reduce the cost. Second reason is that we all deal with big data. There are large number of parameters, multiple number of evaluations, multiplexed assay formats. So there's a huge data. And the focus nowadays has also shifted to an integrated report rather than on a single value or a single number. So these AI or machine learning tools, these computational approaches, they add value to our reports. So our reports will get a meaning or value rather than just numbers. So in labs, we produce many different data from different multiple sources. But in order to get a holistic understanding of the patient's condition and actually drive at a right uh, diagnosis, it is important that we look at an integrated medical data. So all these reports together, plus the clinical history, plus his previous medical history, so everything, if we look at it in totality, then only we will arrive at the best diagnosis for the patient. So only then we will be able to help in improving the decision making, avoid misdiagnosis, also help in further ordering or interpretation of the test, and probably maybe even help in recommending the right treatment for the patient. So the aim is integration of all the data for a comprehensive visualization of the patient's condition. And for all this, AI helps us. It comes into the picture. It makes some tools that we can use to get a composite view of the patient's condition. So there's a lot of research that is going on, and in the implementation of AI in the laboratory medicine, a lot of research work in development of different AI tools that can be used in various aspects of the laboratory. And this is pretty evident from the large number of publications that have really come up in the last few years in AI, machine learning, AI, and even deep learning. In fact, work on implementation of AI has already started, and we have an IFCC working group on that gives recommendations for the use of these machine learning tools in laboratory medicine. Even the European Federation of Clinical Chemistry and Laboratory Medicine has a working group again on artificial intelligence, which is also looking at how these tools can be effectively utilized in our daily laboratory practice. A working group on digital competence has also been formed by the German Congress of Laboratory Medicine. In fact, a special issue on artificial intelligence and big data in laboratory medicine, this was brought out in the year 2022 by the clinical chemistry and laboratory medicine. So all associations across the globe, everybody is working, identifying various applications of these AI tools that can be utilized in our labs. So it is important for all of us also as laboratory professionals, to understand what is this AI, what are the basic foundational concepts of this AI, how it can be utilized. So even if we are not deep into developing the tools, but we should know, if we are tomorrow or today going to use these tools, what does it actually mean to use an AI tool in the laboratory. So artificial intelligence basically involves techniques that equip the computers to simulate human behavior, enabling them to learn, make decisions, recognize patterns, and even solve problems. So basically, it means that AI is a code on the computer system which is programmed to perform tasks that require human reasoning. So automated machines, computers, calculations, they just follow a set of instructions. How this AI is different is because here it will look at the data and then make a reasonable answer, not just basic calculations based on the instructions. So AI powered, they learn from their own interactions with the data and then they give a prediction. So this AI is an umbrella which has different distinct subfields like machine learning, deep learning, and the recent one that has been added is the generative artificial intelligence. So machine learning is again a subset of artificial intelligence. It uses advanced algorithms to detect patterns in the large data sets. So as the name suggests, machine is learning. We give it a lot of information, a lot of data, and this machine or this system will observe this data and look at the patterns in the data and then come out with predictions. So this is what machine learning does. And machine learning is basically the primary way in which we interact with AI in healthcare and even in laboratory. The various tools that have been developed are mainly based on machine learning. Deep learning is further a subset of machine learning. This uses neural networks for in-depth data processing and analytical tests. So this deep learning is a further more complex way of artificial intelligence, and it works on neural networks. So neural networks are basically ways in which the computer tries to simulate how the humans are going to behave or how the human brain works. So how it works, looking at all different datas, what is going to come out. Sometimes even in human behavior we do not know. If you give a lot of data to a human brain also, what is it going to do with that data? Nobody can predict. Similarly, in deep learning, it is you give a lot of data and what is going to be the result of prediction, sometimes we can also not know. So this works like the human brain, mostly like a human brain. The recent addition to the AI tools is the generative AI, and this is the idea of foundation model. So you give some content, some input to the tool, and it will create content, whether it is an article or images or music compositions. This can create your content. It's something again very commonly being used now, like the Chat GPT and the Gemini AI. All these are based on generative AI. So machine learning, as I said, is the most common way in which we interact with AI in our tools. And as the name suggests, you give input or data to the machine. It will uh, observe the data, it will make its own patterns, and then it will give some predictions based on what the data has been given. So depending on how this tool is going to make predictions, this machine learning is further divided into 3 types: supervised learning, unsupervised learning, and then reinforcement learning. So supervised learning models, they are trained by giving them a lot of data with the correct answers or the labels. So once it has a lot of data with the correct answers, it can make its own observations by, making patterns with or collections with the right answers in the given data. So once the model has observed the data with the correct answers, if you give it now some new data, based on that understanding, it will predict the right answer. So it's something like you give students some new material. So the students, they prepare for their exams by learning at the old exam paper. So once the students have read or the old exam papers which have also got the questions as well as the answer, they are ready to take a new exam. So similarly in supervised learning also, you give a lot of data to the machine. This data is labeled, that means it knows what is the correct answer. So the machine will observe this and will make its own patterns and it will formulate its own ways of identifying the correct answers or the patterns. And then when you give it a test data or an unlabeled data, it will form the accurate predictions. So supervised learning models that we commonly use are basically two types, the classification and the regression models. So in classification models, they predict the likelihood that something belongs to a category. If you give some input data, it can say yes or no, disease or no disease, benign or malignant. So it's a binary thing, yes or no kind of an interpretation or prediction it can do. So you give a lot of data from the patient, and then this model will tell you whether the patient has the disease or no disease. On the other hand, the regression models, they predict a numeric value. You give some data and then it will add some numeric value. It will predict the numeric value, like the toxic level of drugs, how much survival years the patient has. So this is a numeric value. So these two models are the commonly used models in the AI tools that we have. So another example is the classification model. So if you give a data to this tool, it can predict whether it will be hot or cold tomorrow, depending on what data has been given. And if it is a regression model, it will accurately predict what is going to be the temperatures tomorrow. So classification is yes or no, hot or cold, disease, no disease, whereas regression model will give you a numerical value to the prediction. The other type of system or the machine learning approach is the unsupervised learning. Now here, these models, they make predictions by being given data that does not contain any correct answers. So you give an unlabeled data to the machine. There are no right or wrong answers that we are giving to the machine. And this model will identify its own meaningful patterns from the data that you have given. And then it will categorize the results based on the patterns. So like in this, if you see the example here, we've given the machine a lot of shapes, and then this machine will look at the patterns in the data, will identify the patterns and draw its own conclusion or own category, how it is going to categorize this data. So here in this example, it has categorized the data based on the shape. So the machine or the model has got no hint or no instructions on what basis it has to categorize. It forms its own patterns, it forms its own rules, it forms its own ways in categorizing the data. So this data can be categorized in a number of ways, and then whatever interpretation that you draw from data is depending on you, which category you want to take. So if you look at this example, so clustering is a form of unsupervised learning model. And if you look at this data again, the data, unlabeled data, is given to the machine, to this AI model, and the AI model will then form its own patterns looking at the data and can cluster it. Now this cluster can be based on either the color or the shape. So there can be n number of ways in which the model will cluster or categorize the data, and then you can utilize your own interpretation of this data based on what type you want to use. So the basic difference between supervised and unsupervised learning models is that just give me a minute. So the basic difference here is that in supervised learning models, we give the correct answers, we train the machine, train the model depending on what we want the answer to be, and then we give them raw data, and then they will predict the raw data or categorize the raw data. Whereas in the unsupervised learning, there are no rights or wrongs. So the model, you give unlabeled data and the model will make categories depending on its own identification of the patterns in the data. So if you see here, we are telling the machine that this is an apple. We are training the model to identify an apple, and then it can predict an apple. On the other hand, if in the unsupervised learning, the model has itself categorized the data into apples and bananas. So, or it could have also categorized it depending on the color. So you get various categories when you ask the unsupervised model to categorize the data. The third type of machine learning model is called as the reinforcement learning. Now these models, they make predictions by getting rewards or penalties based on actions performed within an environment. So its system, this generates a policy that defines the best strategy for getting the most reward. So this type of reinforcement learning is basically used in gaming tools or even in training the robots. So this is mainly for those kind of AI tools. It's like, for easy example, like when you train a dog, although it's not very easy to train a dog, but then again, you can train them by giving them rewards for a correct action or a punishment for a wrong action, and then the dog learns that this is the way that I get a reward. Similarly, for the machine learning tool also, there are rewards and penalties, and this is how they find the best strategy to categorize the data. So just a recap, machine learning basically is the most commonly utilized tool, and three types: unsupervised, supervised, and reinforcement learning. So the most used approach in medical research is the supervised machine learning model. So you give the data with the correct answers, train the machine, then it can categorize your data depending on its own training. And there are various algorithms that can be used for this training the machine model, and like logistic regression, linear regression. So these are basic algorithms that can be used, or which are also called as classifiers in AI. And we will not go into the detail, but all of these can be used to categorize or classify the data. And again, depending on what fits best to your own categorization of the data, we can pick up any one of them. And this is an example of the neural networks which is used in deep learning. So you see here, as I said earlier, neural networks work on something like how the brain works. So there are multiple interactions which are called as neural nodes before an output or an analysis is done for the data. And these kind of neural networks are utilized in image analysis or voice modulations, voice analysis. So this kind of more utilized in the radiological or the pathological analysis of images. So coming on to how this machine learning algorithms can be utilized in our lab. So this is our life cycle of our lab, starting from the test ordering to the reported result. And these tools have been developed, have been researched for all aspects of the life cycle of our labs, starting from the pre-analytical to the analytical and even in the post-analytical phase. So these machine learning tools can be utilized in the pre-analytical phase, where it can be used to identify potential errors in sample correction, like handling or processing based on their historical data, what time the sample was taken, what time it reached the lab. So some algorithms can be utilized, and again the sample collection errors can be identified. Even in sample sorting and tracking, these AI tools have been utilized to detect any anomalies like hemolysis or contamination before the so sample quality or sample integration can also be checked. And again, in another area where in the pre-analytical phase where these AI tools have been utilized is to optimize the inventory management. So depending on how much reagents and consumables have been utilized, these AI tools can predict the usage trend, so that you can always keep your labs with sufficient stock and also not overorder the reagent. So these things have been utilized and have been shown to be beneficial. Now in the analytical phase, again, these models can be used for, and in fact have been researched, or models have been developed to be used for processing of the complex data, and so that faster results or faster analysis can be done, especially where the data is very huge, like in genomic sequencing data. And again, image analysis, like I said, deep learning models have been developed for the image analysis, like in pathology or in radiology. These they can detect or analyze the image, and sometimes even minor errors that are, they can be left out by human eye, these can be picked up by these AI tools. Then monitoring and performance of the analytical instruments, that can be very accurately predicted or very accurately done by these algorithms, machine learning algorithms. Even QC monitoring is very accurately done. Again, in the post analytical phase, the AI tools can automate the generation of the reports and even auto verification. They can also help in the result interpretation because of all the complex, all the various parameters, they can be analyzed together. So the result interpretation gets faster, it gets more accurate. Risk prediction scores have been formulated using these AI tools, and they are also they can also help in better interpretation of our results, and even we can give some therapeutic recommendations based on these risk scores. So various areas where these tools can be utilized in our laboratory. So I will quickly take you all through a few examples of various work that is being going on, and how these tools are being developed in various areas of the laboratory. Before that, an opinion paper, I just wanted to share this opinion paper which was published in the year 2022. And so this paper was from the proceedings of the 3rd Annual European Federation of Clinical Chemistry and Lab Medicine. And the proceedings, they had an discussion and a forum where they all the people, they met. And the conclusion, I'm interested to tell you about the conclusion. So the conclusion of this deliberation was that the ability to convert the value proposition of AI in laboratory will rely heavily on the expertise and initiative from within the laboratory personnel. So the importance was given to the training and education of all laboratory personnel in the AI tools. So if we want this to actually benefit the laboratories, we all need to get trained, or the basic information, basic learning about these various tools. So this is a paper published in the Annals of Clinical Biochemistry, and here this paper discussed the use of machine learning model to identify mislabeled samples, and this identification was found to be much more than the human performance. So using these tools, and so they use different tools, but in all these tools the accuracy was more than the human performance. Then machine learning tools have been developed to for quality control, analytical pre-error detection, and again it has been found that these tools work much better than the simple quantification of the data. So this is a paper where machine learning tools were developed to predict low ferritin levels in patients of anemia. So what they found was that as compared to the specialists in lab medicine, this tool was found to be more accurate in identifying or predicting low ferritin in patients with anemia. So the authors go on to say that using this tool, they resulted in 1 new iron deficiency anemia diagnosis per day. So this is a very significant results that they have shown. This is another example of a model that has been developed for the prediction of Down syndrome in second trimester antenatal screening. So we all know that antenatal screening is done. Now this paper, they found that, now, so why I have shared this is because I just wanted to go into a little bit detail of what they did was that they used a random forest machine learning supervised learning model, and they've used data from 58,000 pregnant women and to train this model to predict Down syndrome. So first, the results of 58,000 pregnant women for the prenatal screening was given to the machine to train the machine as to how to predict Down syndrome. So this label data was given, and then this was tested on 27,000 women with positive Down syndrome. So this is so you first train the machine, then you give a test data, and then you validate the results whether what the machine has or the tool has predicted is correct or not. So the detection rate was found to be 85.2% as compared to the traditional risk prediction, which came out to be only 63%. So this tool was found to be more effective than the traditional scoring systems. So this is another method, another paper which talks about a tool developed to estimate LDL from the HDL and the total cholesterol and the HDL, and they also found that using the conventional formulas, this calculation was much more better. Again, some tools have been developed to reduce the false positive result in newborn screening, and then there are tools that have been utilized for more accurate interpretation of the urine steroid profiles. Then talks about the interpretation of plasma amino acids. So these are all supervised models where you train the machine, develop the tool by giving them a lot of data with the correct answers, and then it can be utilized to predict the answers or make correct predictions for unlabeled data. So these AI tools have also been used to formulate certain scores. So this is a paper which talks about a score which was developed for cancer prediction of cancer using the routine laboratory tests. So cancer prediction using from the routine tests, a tool has been developed to accurately predict cancer. Similarly, this is a tool that these authors, they have formulated a tool to predict acute kidney injury using again routine urea creatinine and the urinary reports. Similarly, prediction of thalassemia, and even in the auto verification, some tools have been developed for the auto verification for the post analytical report auto verification, and predicting the turnaround time for the samples using what time the sample landed, how much time it takes for the centrifugation and all reporting analysis and all that. So the idea is just to discuss that at various levels, whether it is pre-analytical, post-analytical or analytical phase, different tools, people are working on development of various tools to facilitate the laboratory work. So having looked at the various applications and also how we can utilize them to improve our laboratory work and laboratory diagnostics, it is also important to look at the various challenges before we can, completely implement these tools in our daily practice. So the most important challenge is the descaling. So if you rely too much on artificial intelligence, it can lead to descaling of our own laboratory personnel, because our own analytical skills, they may start to decrease over time because we are not using them. We are totally dependent on the AI tools. So it is important to remember that this These tools are for aiding our diagnosis, aiding our skills, and not for completely, replacing the human skills. Again, another major challenge is the data quality and standardization. So across various labs, the quality of data, the reference ranges, the standardization in the in the analysis as well as the reporting, so there is no standardization. So this has a major effect on the implementation of these tools, because you may infer a particular data in some way, whereas the tool will infer it in another way. So this has to be actually looked into before we apply these tools in our practice. Black box models are another challenge. Now, this refers to certain systems where the internal workings cannot be easily understood, and it's very difficult to interpret them. So, the process, how the model is processing or analyzing the data, or how it is making a prediction, is not known. So, what you get out of is again something which we are not able to understand. So, using these models, we have to be very, very careful to actually carefully validate the results before we put into the practice. Again, integrating these systems with our own existing lab systems, lab information systems, will be a challenge. And another challenge is the resistance. So whenever there is something new, whenever there is a change, it is very human behavior to resist this change. So this resistance can come from our own laboratory staff, from the clinicians, where they may find it difficult to interpret the AI results. So there is going to be some resistance. But again, proper training, proper education, awareness, this can we can look at this resistance. These AI tools are expensive, so resources can be a constraint. And then there are ethical issues about data privacy and bias mitigation. These also have to be looked into before we can utilize these tools. So if you really want to go into this implementation, it has to be used to enhance the diagnostic performance and not replace the human expertise. Human skills, human expertise will always stay before these tools. So which tool has to be used, in what way it has to be used, how it has to be validated, this is all in our hands. Again, validation is very, very important, and this validation should be conducted in various locations before it is implemented. So like I said before, how I interpret or infer a data may be different than this being done at some other place. So this tool should be validated at multiple places before it is put into use. So the take home message would again be that although these tools, they hold a transformative potential, but again, this has to be used very responsibly, and not immediately put into use, but responsibly validated and then checked properly for performance, and then only integrated into our own practice. Thank you.
Thank you so much, ma'am. This was insightful lecture on the topic. This topic, AI in biochemistry, will prove very useful in upcoming future. Now I request our participants and chairpersons to ask any
Thank you,
questions.
ma'am. Thank you, Shivani ma'am. I would like to extend my sincere gratitude to ma'am for such a valuable session on artificial intelligence in clinical biochemistry. And I truly hope it proved helpful and informative for PG students and members in attendance. Thank you, ma'am. Thank you, Shivani ma'am.
Thank you so much. Thank you.
Thank you. Thank you.
Thank you, ma'am, for such a nice, wonderful sessions on role of AI, machine learning, deep learning, generative AI in biochemistry lab, which will be very helpful for our new PG students and faculty also. And congratulating original team for organizing such a wonderful seminar. And thanks for inviting me. Thank you.
Any questions from audience?
Dr. Rima Berry, ma'am, I request you to ask any question.
Very good afternoon. First of all, I'd like to thank Dr. Anita for inviting questions for this wonderful session. and also Dr. Shivani Basu is really done a very good job talking about the same, because this is something which is very new, and lot of talk should be carried out about this so that people become awareness. Lot of awareness is required so that we can use these newly developed tools in our day-to-day practice of clinical biochemistry and much more lab medicine. So my one question is, speaker, Madam, could you also elaborate some of the applications or examples?
Sorry,
Hello?
I'm not very clear.
Am I audible?
Can you please repeat your question? I will request others to please mute themselves. We are not able to hear the speaker.
Okay. Am I audible now, Dr. Shivani?
Yes. Yes,
All
please
right.
tell me.
I've just put the phone closer to my, yeah. So
Yeah,
my
yeah.
question is, could you share some examples where
वैक्सीनेशन हो रहा है ना
I think some background noise is there? Hello?
Yes, please go on, Dr. Reema.
Yeah. So I was asking if there are any examples you've come across while preparing your talk or otherwise in your experience where artificial intelligence and machine learning are put in day-to-day practice in a clinical laboratory in India.
Yes, in India also, these tools for algorithms for data interpretation, like this one for LDL calculation, this is being used at many places, and even for auto verification, this is also in place. And there are maybe few others also, but most of them are still, in the research phase. It's not like a tool is available and anybody can use it. They're all still in the research.
Okay, thank you. I'll share a small experience of mine. What I have observed that especially in radiology, all the X-ray images, screening of X-ray images and reporting is being done in using artificial intelligence. That's one. And digital pathology has adopted AI in a very good way, and where large volume labs are reporting routines, screening of routine the slides, and also urine clinical pathology, and it is being reported. And they have placed some algorithms where certain alarms are there or certain flags are there, which are, then given to the pathologist, the human pathologist, to be done.
Actually, I think what you're talking about are again not AI tools. They're all computational instruction based tools, algorithms. So like, like it's like the EGFR we calculate online, or BMR we can calculate. They are all formulas which are given. So even in these pathology tools that you're using, even in our LIS, I think most of us have LIS. There are, when the results go off, either too high or too low, they get flagged. So they are not, this is not AI tools, these are basic computational tools. The difference is that in AI it will formulate its own inference and then give you an integrated answer. So such tools are not now at present available online to buy and use. They're still more in the research phase.
Yeah, actually they are not available for purchasing, but some laboratories, I'm sharing that they have in-house developed these tools, and they are
maybe
being
in-house
used.
they have developed,
Yes.
and they are still in the, they have started utilizing it, maybe.
Yeah. Yes.
Yeah.
Thank you.
Thank you so much, Dr. Reema ma'am. I request Dr. Shilpa Jain ma'am to ask any question if there.
Good afternoon, everyone. This was, first of all, I would like to congratulate Dr. Anita and her team for organizing this event, and Dr. Shivani for delivering this wonderful talk. Of course, this AI, artificial intelligence, that has swept in all areas of our life and lab medicine. It is undergoing huge transformation due to integration of artificial intelligence. Dr. Shivani has very in a very simple manner, she has explained how these various tools can be developed and they can be useful in different areas. I guess lots need to be done, and it's just in the preliminary phase. But as she has also stressed, I also agree that it does not eliminate the human expertises, because of course, ultimately the tools have to be, the computers are to be taught by us only. So the need is to develop tools in a manner that they are useful and they are accurate. So I guess it's a very, it's going to be very promising. And thank you, Dr. Shivani.
Thank you, Dr. Shilpa.
Thank you so much, Dr. Shivani, Dr. Rima Bhari ma'am, Dr. Sangeeta ma'am, Dr. Sunil sir, Dr. Shilpa Jain ma'am, for sharing your time and your experience with us.
And journal writing.
Madam, it's Dr. Kolaya speaking. Madam, it is very wonderful talk on AI. Madam, it is a very good session.
Thank you, sir.
Congratulate you for this session, madam. But for the members, can you please guide us where this training can be taken? What are the steps, or in where the training to be, on the language or for instructions, or so that they can understand this more in future?
So I think there are the ICMR portal also, where we do the BCBR course. They also have some AI training, some small programs. And then I think the Karam Yogi portal also, if you all know, if you're in the government job, you will know that we have, that also has certain small these courses for in basic awareness. And then like I think somebody just mentioned that IITs also hold some small programs for these, how to use this. Then certain tools are available freely also online, and they are very simple, user friendly. If you have some basic knowledge of how computers work, they can be used. Small simple coding is required, and they can be utilized.
And thank you, ma'am.
Thank you.
Now, for this, I want to invite Dr. Shashma Bijay ma'am, our speaker, and honorable chairpersons, Dr. Prabhas Bhavsar sir, HOD Biochemistry, GMC, Dungarpur, Dr. Alkamina ma'am, Associate SMS Medic, Dr. Garima Gupta ma'am, Sir, GMC Pali, Dr. Shishma Bijay ma'am, Professor and Head Biochemistry, NIMS Institute, Jaipur, MBBS from Rajiv Gandhi University of Health Sciences, Bangalore, and MD from RGUHS, Bangalore, with gold medalist in 2014. He has done fellowship in diabetes, fellow of the College of General Practitioners, fellow in clinical nutrition, advanced course fellowship in diabetes, FCGP, fellow of the College of General Practitioners, fellow in clinical nutrition, advanced course in clinical nutrition, MBA Hospital and Healthcare Management, and she has completed ACME, that is Advanced Course in Medical Education, pursuing PhD in Medical Biochemistry, Young Scientist Award in AMICON 2024, and SPMC Quiz Award in ACBCon. She has won Best Research Paper Award in International Conference Amman, Jordan 2024, and Women Research Award in 2020 International. He has participated in Health Summit meeting in 2025 at Bharat Mandapam, Pragati Maidan, New Delhi, organized by NIMS University, Jaipur. She has more than 65 plus publications till date, including PubMed, PMC, Corpus Index journals. I to proceed with your session.
Thank you, sir, for
Dr.
the
Shishma,
nice.
ma'am.
Thank you, sir, for the nice introduction, and I'll be proceeding with my talk on the topic.
Yes, ma'am.
Give me a minute. Just
Yes, ma'am. Now we can see it.
Sir, is the PPT visible?
Yes.
Is the PPT visible? Okay. Okay. Respected seniors and my dear colleagues and juniors, I first of all thank Dr. Anita Verma ma'am for giving me an opportunity to present on this platform. I welcome you all for the session on the topic advantages and limitations of total laboratory automation. So the contents of the slide include total laboratory automation, advantages with some few case scenarios, limitations, conclusion and take-home message. Coming to the case number 1, I'll be dealing with the case scenarios rather than directly jumping into the topic. A blood sample from a 4-year-old boy with abdominal pain was sent to the laboratory from the accident and emergency department. Some of the results were as follows. Total bilirubin, ALT, ALP, we can see that ALP is 400 and the reference range mentioned as less than 250. Albumin 4 grams per DL and GGT 14. So almost all the parameters said to be under the normal limit, but the ALP you can see that it is around 400, but the normal range mentioned it as less than 250. So can somebody can answer me or can text me what would be the pre-analytical error in this case? The patient age was not given on the request form due to which the computer automatically used the reference ranges for the adults, hence ALP was raised, but in fact it was within the normal limits for a 4-year child, which is around 60 to 425 units per liter. So this is one of the pre-analytical error which cannot even be minimized by using the, which can be minimized by using the automated systems. So when you look at this picture, the picture 1 depicts the system, the laboratory process without any automation. You can see a number of people, the manpower required is 7 around, and most of the machines are apart from each other. They are not interconnected or they are not integrated. And the pre-analytical workstation is separate and the sample stockyard is separate. And when you look at the image that is depicted 2, so it's a partial automation where you can see that the integrated, some of the machines are integrated, like we have a pre-analytical workstation integrated with the clinical chemistry, immunochemistry and sample stackyard. But the hematology analyzers are not integrated. We get this a partial automation. The number of manpower again goes down. When we look at the total laboratory automation, almost all the phases, pre-analytical, analytical, and post-analytical are integrated, and the manpower again goes down to 2. So this is a picture that is depicted in Clinical Chemistry Lab Medicine, published in the year 2019. So what is total laboratory automation? It refers to advanced robotics and information system to streamline and automate laboratory process from sample reception to the result reporting. So the overall objective of this total laboratory automation is to enhance the efficiency, accuracy, turnaround time while minimizing the human errors. It integrates basically pre-analytical phase, analytical phase, and post-analytical phase. As we all know that the analytical phase is the most automated as per the more research and development efforts are focusing on increasing automation of pre and post, because in the analytical phase mostly the developments are up to the point. It is already we are using the automated systems, but the more and more research is required still at the level of pre and post analytical process, because the demand for TLA has increased with growing need for high throughput testing and standardized diagnostics. This innovation is transforming clinical laboratories into fully automated and intelligent systems. So let us look into the second aspect. What are the advantages of total laboratory automation? Dr. Shivani ma'am has most of the points she has discussed, but I will add on to the some of the points as the topic is advantages and limitations of the total automation. So the number one advantage would be lower cost on the long term. So if somebody is expecting the cost benefit analysis at the initial point of or the short term, definitely it is not going to work out. But if we look at the long term and the number of samples in a medium size laboratory or the very large size laboratory, we can expect for the lower cost and the long term analysis. The net benefit, the return of the investment is indeed more appreciable on the long term after reaching such something called break-even point when the higher initial cost will be offset. So that's about the very first advantage of having total laboratory automation, because when we look at the laboratory, it is money, manpower, and the material that really matters, apart from other things, along with the quality reports and the right reports to the right person at the right time. Point number two, the advantage is decreased congestion in the laboratory. So as the total lab is under the automation, the requirement for the human power goes down. So there's a decreased personnel who is working in the total laboratory automation. So there's a congestion in the lab will be decreased. For this, we need to ensure the optimized layout of the integrated workstation prevents the technician moving back and forth many times between the analyzers, minimizing the distance covered by the personnel who is performing the multiple analysis on different instrumentation. Point number three, it is improved efficiency. The total laboratory automation may be variably effective in order to reduce the turnaround time and concomitantly increase the laboratory productivity. Within a short span of time, we can perform n number of samples and n number of tests. The results can be reported in a very short duration of time. Notably, the assembly lines can transport a huge number of blood tubes or secondary liquids at a high speed between 3,000 to 10,000 tubes per hour at a speed of 20 to 100 meters per second, thus considerably offsetting the manual transportation. This manual transportation time delay can be overcome using the pneumatic blood transportation systems, which will be connected from the hospital to the central laboratory. TLA enables the pre-analytical phase of the TLA, especially it enables checking, sorting, decapping, centrifugation, and fully automated liquid aliquoting of different tubes of different types and sizes, followed by circulation of automatically labeled secondary aliquots into TLA, thus overcoming the challenge of adapting different analyzers to different types of tubes. Now coming to the fourth advantages, it is the one of the again important advantages that improves sample management. Query host communication has virtually eradicated some high risk activity connected to the manual transcription of the data, and also it has enabled reducing the turnaround time. Looking at the case 2, a 32-year-old non-pregnant female, she visited the outpatient department with complaints of fatigue, weakness, occasional dizziness as a part of her routine health checkup, and complete blood count was ordered. Primary test was CBC, so the report shows hemoglobin 9.8, MCV, MCH all are decreased, and RBC count is normal to high. As per the lab protocol, any hemoglobin less than 11 in female automatically triggers a iron profile. What we call this as? There's something called reflex testing and add-on testing. This is one of the important advantage of the automation, because once we feed the instrument, the data is already given that if the hemoglobin of the female patient goes less than 11, automatically the machine is able to perform or it triggers the add-on test and the reflex test, which include the iron profile. So this is called reflex testing, which is one of the important aspect of because it definitely minimizes again repeat sample collection. Again, you need to call the patient because patient has come to the OPD. Again, she cannot come back to the same thing for the same test, right? So this is how the integrated systems have very helpful in the patient diagnosis and the management, because one single report will not yield any better conclusion, but the integrated iron test profile along with the CBC report will yield the better diagnosis, so that nothing will be missed out. Serum iron around 32 and TIBC, all that. So you can see that the iron is lowered in this patient. So this is called reflex testing. And there's something called add-on testing, which is going to be initiated by the clinician. Given the chronicity of the age of the patient, clinician requested add-on test from the preserved serum sample within 48 hours. This is one of the again advantage that it will minimize the repeat sample collection without recalling the patient. That is vitamin B12, folate and CRP has been advised to the same patient because we can see that the vitamin B12 is again lowered. So this is one of the, because patient has to, we are not treating the symptoms of the patient, but we are treating the disease. To treat the disease, the proper workup, the investigation has to be very much essential in order to arrive at the proper diagnosis and the proper treatment. Coming to the, at the end of the add-on test, reflect testing, we yield something called the final diagnosis. It is a case of isolated iron deficiency anemia. Further, the clinical management will be done by the physician. Thus, reflex testing improves diagnostic efficiency without requiring multiple blood draws. Present algorithms in TLA as LIS can automatically trigger the appropriate reflex profile, that is iron studies for low hemoglobin. And also the add-on testing conserves the sample integrity, speeds of the diagnosis and avoids patient discomfort. So they're particularly valuable in high throughput labs using automated platforms. Like currently in our lab, we have Vitros 5600 integrated system, and we have Cobas as well, and Beckman Coulter systems. The another advantage of this TLA is that increased traceability. Traceability in laboratory automation ensures every step of the testing process from the collection to the reporting of the results accurately logged, and it is easily auditable. This enhances quality control, reduces errors, and supports regulatory compliance. One of the biggest advantage, because nowadays it is a passion or the trend that every lab wants to go for enable accreditation, CAP accreditation to attract the financial aspect as well as to gain the popularity. So everyone is looking for this, right? Even medium-sized lab, small-sized lab, irrespective of the number of samples. So by adopting this automation process, most of the errors, the SOPs are almost automatically it is updated, and most of the work, the human power or the human work load decreases, and the total automation will ensure the quality aspect of the results and the quality control, equals all that. So it seems to be profitable for many aspects related to analytical quality, such as the quality specification of the assay, traceability of the calibrators, improved quality and stability of the reagents. Then improved quality of testing. Standardization and harmonization are the two crucial issues in laboratory diagnostics. A paradigmatic example has been published by Hawker et al. In the year 2022, who showed that implementation of the major automation system in a medical laboratory was effective to decrease the number of lost specimens by over 50%. So it's a significant number. And point number 8, lowers the sample value. Unlike in a manual testing and the semi-automatic testing, we require quite higher volume of the sample, but whereas very few microliters of the sample would be definitely sufficient for the total automation process. And especially it will be helpful in the children. Basically, we want to avoid double pricks in the children and repeat samples. So it would be very advantageous. And it is more efficient integration of the test results and lowers the biological risk for the operators. Like if the sample is having biologically hazardous, like viral infection, HIV, or some. So manual pipetting or, a sort of, there's an exposure to the risk for the person who is performing the test or sorting the sample or preparation of the sample, exposing the patient, exposing the technician to the high risk of acquiring the diseases which cannot be, so they are biologically hazardous. So this kind of risk can be prevented using the total automation process, because the pre-analytical aspect is also taken care by the machine itself. So this could be minimized. Then at the same time, the staff needs more knowledge, and each should be having good skills to operate the fully automated systems. And at the end of the day, the technician will be having a job satisfaction of the, because whatever the work that is performed in the automated process, it has the error free, because pre-analytical analytical quality issues are ensured. The job satisfaction is higher, because the research paper do says that the technical staff performing on the automation versus semi-automation and the manual testing. So the job satisfaction was very much high in the persons who are working with the automated systems. So if you look at this case 3 again, we talk about automation so much, but still the sample collection errors are still encountered, right? So if you look at the image number 1 and image number 2, we can see that there's a lot of difference with the color of the blood, the whole blood. You can see the the image depicted when the one, it shows when this patient sample was given for the hemoglobin testing, it was showing around 8. And the repeat sample showed around 13. Actually, patient was not having anemia. But why did this error occur? The technician who was drawing the sample without stopping the IV line, the blood sample was drawn with the connected IV line without stopping the drip. So leading to the sample dilution and yielding the less hemoglobin results. So again, this aspects cannot be again taken care by the automation system. Then coming to the with that introduction, I would go with the topic limitations of the total laboratory automation. Again, on short term, if somebody is expecting within a very short time, cost benefit analysis, definitely it will be a failure because higher cost on the short term, because you may take the machine for rental, partial rental, or fully purchased, and you cannot expect that you are going to overcome the cost or the investment that you have put in the initial stages within a short span of period. So one has to have a patience, and it has to be on the long term. And point number 2, but again a question mark, because there's rapid development in the automation every now and then every year. So again, making a decision on purchasing the equipment completely is also a question mark, because we at least ensure that another 5 years there should not be any updation or the new instrument coming with the new features, right? So again, this is one of the very debatable situation. And the second limitation is increased cost for suppliers, maintenance, energy, and supplies. The implementation of new hardware, essentially represented by pre-analytical workstations, assembly lanes, and sample storage units, carries subsidiary cost for running the system and for supplies. Coming to the third limitation is, Dr. Shivani ma'am discussed some of these points. The space requirement and infrastructure constraints. Again, the total automation requires a larger space to occupy, and if the adequate space is not there, then again it will be a constraint in the implementation of TLA. Then overcrowding of the personnel. If suppose the technical staff are not well skilled to handle the each integrated part or the each integrated analyzer, maybe 3-4 technicians will be posted into the, if they are not well versed with, suppose a clinical biochemistry technician, if he is forced to work on the hematology analyzer, it is little difficult because there needs a upgradation of knowledge on the hematology, because he is well versed with the clinical chemistry, right? So in this case we require adequate staff again. So unless they get trained in both the areas. Then coming to the very fifth limitation is increased generation of noise, heat, and vibration. All the analyzers are connected to each other in a single system, and in a given space, definitely it accounts for the lot of generation of heat and noise and vibrations. Increased risk of downtime. Because we are so much addicted to the adopted or addicted to the newer automation, all the technical staff, they might lose their skills, right? In which they were handling in the manual phase, in the pre-analytical phase or the post-analytical phase. Suppose there is an instrument breakdown without a proper backup, that's going to be a very, very critical situation to handle large number of samples by a minimum staff. So there's an increased risk of downtime. So when we are implementing total laboratory automation, we need to ensure proper backup, otherwise there may be a failure of the system, accounting for the delay in the reporting and the performance of the samples. Then again, point number 7, psychological dependence on automation. People are so much addicted to the automation. Suppose there may be a day in which something fails in a software or some backup is not available. Again, it is a very difficult for the technical staff to go back and develop the skills again, and they get a lot of psychologically depends on the automation, so they will not be able to work. So this is another important limitation of the TLA. And the important again, one more limitation is differential requirement for sample management. Maybe somebody has come for HbA1c test, we need EDTA sample, we need heparin sample for, and we need plain samples for other tests. So we need different kinds of samples and differential requirements for the sample management. Maybe one of the, again, limitation of the total automated system. And the current guidelines, they mandate that citrated sample for hemostasis testing should be centrifuged at a rate of 1500 gravity for 15 minutes. Therefore, consolidating hemostasis testing within TLA remains again a debated issue. Now, the ninth limitation is generation of the potential bottlenecks. This problem really comes when we have a stat sample or urgent samples, because we are working on a larger sample load and the integrated systems, and suppose we need a stat results. So that is where the AI tools again coming to the picture, that the priority samples have to be again given the chance to perform, and later the routine testing. In that case, even the routine testing might get delayed. So again, it's again a debatable situation. And the risk of in that case, the article says, the article which is published in a clinical chemistry, the problem to this solution, they say that you can use point of care testing, validated and verified POCT would be helpful in such kind of situations. Then the next limitation is risk of transition towards a manufacturer driven laboratory. Since it's going to be a closed system, we are going to depend on one single vendor. That may be again additional risk, because highly automated strongly depends on efficient software programs and constructive partnership with the manufacturers. Then the another limitation is disruption of the staff trained in the specific technologies. Development of so-called core lab, where a larger part of the lab staff will be committed, is an obvious consequence of consolidating many diagnostic areas. The larger volume of knowledge is required, and the lower the competency on the specific technologies. So this is a table which highlights the advantages and limitations of the TLA, which we have already discussed about it. And moving on to the case 4, a 10-year-old boy was brought to the diabetic information stand at a show. A voluntary screening group had just diagnosed diabetes on the basis of finger prick glucose level over 11 millimole per liter. His distraught mother begged for the help. So what is wrong in this case? Because no history of diabetes, no family history, and the child was normal before this, right? The problem in this case is that it was a pre-analytical error, which was accounting for, again, which cannot be dealt by the automation. She was clutching a large sticky lollipop, and she was confiscated because diabetes cannot eat sweets. After a thorough hand wash, his finger prick glucose was 4 millimole per liter. Thus, conclusion is that the opportunity to connect multiple diagnostic specialties to one single track has been proven effective to improve efficiency, organization, standardization, quality, and safety of laboratory testing, while also providing a significant return of investment on the long term and enabling the staff requalification. Developing a model of TLA presents some potential problems, mainly represented by higher cost on the short term, enhanced expenditure for supplies, space requirement, infrastructure constraints, staff overcrowding, increased generation of noise, heat, higher risk of downtime, psychological dependence, critical issues for biospecimen management, disruption of staff trained in specific technologies, along with the risk of transition toward a manufacturer's guided laboratory. Again, job displacement, unemployment will be the another problem with the total laboratory automation. Hence, the accurate analysis of all these theoretical advantages and limitations should guide laboratory directors to configure a local solution suitable for meeting current testing trends and handling future demands. With this, the last slide is take-home message. Automation does not replace the expert. It empowers them to focus on what truly matters, better patient outcomes. Thank you, one and all.
Thank you so really informative session. I would
Thank you,
like
sir.
to thank you, ma'am. I would like the chairpersons and participant to ask any question.
Thank you, Dr. Sharma, for sharing your expertise and insights
enriching our understanding of total laboratory automations. Your presentation was really very informative and thought-provoking. And I would also like to thank Dr. Anita Verma and Ambicon for the wonderful CME. Thank you all.
A very good afternoon to all of you. Thank you, Anita ma'am, and a big congratulations to her team also for organizing such a wonderful CME. It is a very useful thing. And thank you so much, Sushma ma'am, for a very well explained presentation. The case studies you included indeed made it quite interesting. And it seemed that reflex testing and add-on testing, they seem to be the most important advantage for the patient welfare for as far as the TLA is concerned. Ma'am, just a general query, if it can be discussed, are there any set of like standard rules which should be followed if we are setting up a totally automated lab?
Actually, ma'am, it is still into the research area, but as such, we are having partially automated systems. But for to develop a TLA, of course, there are certain protocols and certain guidelines which needs to be followed. And the research article, I will share it in the group. Please, you can please go through that, ma'am. But there are set of rules and regulations to be followed for the setting up the TLA, ma'am.
Thank you so much, ma'am. It will be very nice of you if you are sharing the research article. It will be
Yes,
helpful, ma'am.
sure,
Thank you.
ma'am. Sure, ma'am. Thank you, ma'am.
Thank you so much, ma'am. Prabhas Bhassar, sir. Are you there? Dr. Prabhas, sir. I think he's left the chat. And all honorable chairpersons. With this, with a vote of thanks or speech, with our HOD ma'am, Dr. Anita Verma ma'am, Professor SPMC Bikaner, Rajasthan. Ma'am.
Good afternoon to one and all. I express my sincere thanks and gratitude to our principal, Dr. Gunjan Soni sir, the chief patron for the event, who has helped us at every step. I would also like to extend my special thanks to the dedicated team of my department of biochemistry, SPMC Bikaner, whose constant efforts made this event possible in the first place, especially all faculty members and all residents for their untiring task at the ground level for the success of this CME. I also thanks to Dr. Anita Devanath ma'am, Honorary Secretary AMBI, for unconditional support. I extend my heartfelt gratitude to all the guest speakers and chairpersons, distinguished faculty members of many institutes. I am highly thankful to Dr. Rajneesh Parasar, who gave IT support for the CME. On behalf of organizing committee, it is my duty to mention special thanks to all hospitals and publication houses who contributed directly or indirectly to this CME. I am highly thankful to all the esteemed delegates who have registered in a huge number to make this event already a grand success. More than 500 delegates have registered for attending the CME. Finally, I extend my thanks to everyone who has contributed directly or indirectly in any capacity for organizing these CMEs. You are participants are thanked for all your great scientific input and for many fruitful deliberations and scientific interactions. We have had an excellent experience in hosting you for so far as wonderful guest and hope our effort will be remembered in your sweet memories for a long time. Thank you all once again for being with us. Thank you very much. And I would like to mention this point that all the members who have registered in the CME will be getting their certificates in their Gmails. Thank you all.
Thank you all Thank honorable chairpersons for making the session insightful. With this, we end our session. Please into the registered email ID. So, thank you, everyone. You can leave the session.